Good afternoon, and thank you for joining us today for this very important webinar, How to Sustain Indoor Air Quality and Keep Schools Open. My name is James Collins. I'm the Senior Director of Business Development at CSBA, and I will be facilitating today's webinar. Before we get started, I want to make a few announcements. Excuse me. If at any time you have a question for presenters or technical issue, please use the Questions tab of your GoToWebinar dashboard. If you do not see the webinar dashboard, it may be collapsed. Look for an orange arrow at the top of the right corner of your screen. Click on that arrow and it will expand the dashboard. And at this time, I would like to turn over to Richard Doss, Senior Vice President at LifeWings LLC. Take it away, Richard.
Thank you, James. I want to make sure everyone can see my screen. Think so? Good. I want to welcome everyone today and thank you for taking time out of your busy schedules. My name is Richard Doss. I'm a Senior Vice President with LifeWings Peak Performance. We're going to spend about 40 minutes or so discussing a few different topics today that are important to us, important to public health, and to, of course, the California School Board Association. And we've got a nice discussion set up. We're going to talk a little bit about some science and medical management background and research on the COVID-19 situation in schools. We're going to talk a good bit about some of the strategies to improve indoor air quality. We'll also mention some of the key tools that we can use and the importance of a building readiness assessment. We'll talk a little bit about some of the outcomes, the importance of a strategic air monitoring program, and some of the skills, expertise that's required to be successful. I want to introduce our three speakers. First, today we have Dr. Scott Altman. Dr. Altman is an emergency physician by practice, spent time on faculty both at Johns Hopkins and at Northwestern in Chicago. He currently leads the strike force team at Advocate Christ Hospital in Chicago, so been involved in COVID since the very earliest times, and also has done a tremendous amount of consulting. Scott and I have worked together for several years, and most importantly, he's worked internationally and worked in any number of countries. Also with us today, we have Dr. Mark Weir. Dr. Weir is an environmental scientist and at the Ohio State University College of Public Health. And Dr. Weir is very involved with both wastewater sampling, air, and epidemiological sampling. Works with on the governor's task force in Ohio, involved with schools, involved with corrections, involved with long-term care, and also has worked with his colleagues at several other universities, Drexel, Michigan State, Arizona State, to name a few, on quantitative microbial risk assessment, and he'll be sharing some of those experiences with us today and some of his research background. And we also have with us Randy Christensen. Randy is a partner and principal at KFI Engineers, our partner firm, engineering firm in Minneapolis, St. Paul, Minnesota, offices in Arizona, Ohio, Wisconsin, and Iowa. And Randy, most importantly, and his team have been working over the last 12, 13 months, have done over 200 COVID HVAC assessments among schools and a number of other county type facilities. He'll talk about different types of facilities today. And they've also done some very impressive research on different types of technology and air cleaning. So those are our three speakers today, and Dr. Altman will get us started on respiratory viruses. Dr. Altman.
Okay, sorry about that. Good morning, and thank you, Richard. In negotiations, there's a concept called anchoring. The first person who tells us something locks that idea in our minds, and it's much more difficult to change a commonly held belief than it is to create one in the first place. I'd like to tee off our discussion today with a story about how a tiny but critical COVID detail became anchored in the scientific community and from there spread to the world as a whole, and in the process of telling this story, try to convince you that we need to change our approach to managing the air in our buildings. Next slide. In the background of this slide is this year's CDC influenza map. All the green of that map shows us that the flu was almost non-existent this year. In the foreground is a line graph of all influenza-like illnesses of the year indicated, looking back over the last several years. The line with the red triangles at the bottom of this slide shows the incidence of non-COVID influenza-like illnesses this past winter. With masking, social distancing, hand washing, and shutting down, you can see that we virtually eliminated all of them. As we reopen our societies, though, respiratory viruses will return to their higher historical curves. We can't relax just because we appear to be turning the corner on COVID. And we also now know that we have to be better prepared for the next pandemic, which is unpredictable beyond knowing that it will happen and likely sooner than later. Next slide. The middle box of this slide shows that the COVID virus is spread from the source in the red circle on the left to the recipient in the red circle on the right in 3 different ways: aerosols, droplets, and contact, each of which requires different mitigation strategies. The distinction is critically important, as the higher the circle in the box, the more difficult it is to manage the transmission. We have focused a lot of attention this year on the bottom 2, with masking, social distancing, hand and surface washing. We'll talk in a minute about why. As a society, we haven't done a very good job talking about or managing aerosols, the upper method of transmission, and I hope to convince you today that that was a mistake. Next slide. Viruses are tiny, smaller than a micron, and there are 25,000 microns in 1 inch. Viruses are smaller than particles of dust or even smoke. We know that in general, respiratory viruses do not float in the air by themselves naked, but instead are breathed, coughed, or sneezed with tiny coatings of saliva and or mucus. The size of that particle of saliva or mucus-coated material is really important, as it determines how the particle will flow through the air, in particular via aerosol or droplet. Aerosols float for long periods and travel long distances. Droplets are heavier and they quickly drop, as their name implies. The pivot point for that difference has long been thought to be 5 microns, much larger than the respiratory viruses themselves. That implies that most of the virus we exhale, cough, or sneeze would be in droplets and would fall within 6 feet and could be avoided by distancing and washing. Next slide. There have been a lot of studies evaluating the effect of a cough or a sneeze. This particular study by Drs. Wei and Lee is one such simulation experiment, in this case using glass beads to analyze some of the flow variables. I don't think the details are very important. In the end, the exercise shows what we would intuitively expect. Smaller particles travel farther and stay airborne longer. You can see that in the 3 black boxes on the right side of this slide. Aerosols cannot be eradicated by hypervigilant surface cleaning. They require much more complicated air handling techniques. Measles, chickenpox, and tuberculosis have long been known to be highly contagious, since they've been proven to be spread by aerosol rather than droplet. In the hospital, they require careful isolation, negative airflow rooms, and N95 masking. So the critical question is, how small is too small? These authors concluded that a cough or sneeze will result in a combination of submicron, less than 1 micron, and over 10 micron distribution. Common thinking then would place some of these particles we cough or sneeze in the highly risky aerosol range, like measles, and some of it in the less risky droplet range, sort of like the middle box on the right of the slide. Next slide. But it turns out common thinking was not uniformly believed. In the scientific community, it was controversial. Only a few months into the pandemic, 241 scientists advocated an opinion piece that normal respiratory exhalation, talking, and coughing resulted in micro droplets, small enough, remember that small enough again, small enough that the 6-foot distance was not only not protective, but caused WHO and the CDC to entirely miss what they felt was the principal method of transmission, aerosols. So what does small enough mean? How do you know what is small enough? Because that determines aerosol versus droplet and really determines the principal method of spread. In fact, if indeed aerosol is the way this is transmitted, it would lead us to what the New York Times called hygiene theater, excessive cleaning and washing at the expense of managing aerosols. Not that cleaning and washing are bad in this scenario, but too much of it isn't necessary or wouldn't be necessary, and cleaning, washing would be in addition to, not instead of cleaning the air. Well, who is right? It turns out to depend on what size you believe to be an aerosol versus a droplet. Remember, common thinking has long been 5 microns. We were anchored on that number. Next slide. This article in Wired magazine reads like a whodunit mystery novella. It's an easy read, it's both entertaining and informative, and I recommend it highly. 5 microns had long been accepted to be the fulcrum for the size that separates aerosol from droplet, and that was the rule that drove this WHO and CDC to call for 6-foot separation and the encouragement of rigorous cleaning of surfaces the droplets fall onto. That didn't make sense to a Dr. Lindsay Marr, an aerosol scientist at Virginia Tech. Her research led her to believe that the 5 micron number was not only wrong, but substantially wrong. With the help of a graduate student, Katie Randall, she went hunting for the source of the 5 micron number that the CDC and WHO were anchored on. To make a long story short, it turns out that the magic aerosol droplet fulcrum is actually 100 microns, much larger than the common 5 micron myth and substantially larger than both Drs. Weir and Lee's 10 micron tail of their bell curve. In other words, what Dr. Marr found was that we exhale almost entirely aerosol, which is much more measles and tuberculosis-like transmission models, and implies that we should be much more focused on our air than our surfaces. After months of digging, what Katie Randall found out was that in 1955, a Harvard engineer studying tuberculosis had published a book that caught the attention of Dr. Alexander Langmuir, who was at the time the chief epidemiologist at the newly established CDC. Dr. Langmuir was studying biological warfare, and he mistakenly conflated 2 important numbers in Dr. Wells' publications. Dr. Wells had identified the 5 micron size as the pivot point for the ability of the nose and throat to filter and prevent particles larger than 5 microns from getting into the lungs. So 5 microns was the size that we could protect ourselves from, but he also found that 100 microns is the pivot point for aerosol versus droplet. Late in Dr. Langmuir's career, he corrected his mistake, but it was too late. It had already been anchored in the scientific and in the CDC communities. So I want to pause for a moment and reflect on this critical point. A COVID-containing particle smaller than 100 microns will aerosolize and float long distances through the air where others in the room can breathe it. A COVID-containing particle smaller than 5 microns can evade the natural defenses of the nose and gain access to the lungs, where it can use one of those famous spike proteins to enter the bloodstream and spread throughout the body. The problem is aerosol, not droplet, and the solution is air hygiene, not surface hygiene. Next slide. Belatedly, both the CDC and WHO changed their guidance, but they did so rather quietly and too late to really change common behavior. We were already anchored on the idea of masking, distancing, and washing. And besides, it's a lot easier to wash our hands and wipe down surfaces than it is to deal with airborne aerosols. So what do we do now? That's exactly the question that brought us together, a healthcare consulting specialist, an emergency medicine public health doctor, an environmental engineer who specializes in microbial risk assessment modeling, and a mechanical engineer who specializes in air processing and ventilation. And that's exactly the question we hope to answer for you today. Next slide. And by the way, even if you don't buy the aerosol story, cleaning the air has been demonstrated repeatedly to result in improved student cognition and performance, decreased staff and student illness, employee sick time, and everyone's satisfaction. And with that, I'll pass the baton to Dr. Weir.
So what I'll be talking about is a little bit more about aerosol dynamics, some on the aerosol science, and then how this incorporates into what we consider the ability to quantify risk. So what we're seeing here in this slide is we're seeing a simulation that we put together using a method called computational fluid dynamics. And that method, what it does is it takes the room air and it breaks it into a very fine grid. And at each point in the grid, it solves a three-dimensional equation for where the air and then any bioaerosols that are attached, or not attached, but are in the airstream in that little grid are moving to. And so what we did was we set it up as three people who were coughing in a room. The person with the pink is somebody who has currently that we didn't catch, who has COVID-19, who has a SARS-CoV-2 infection. So what you're seeing is not virus. What you're seeing is bioaerosol that could possibly contain virus, because every last piece of aerosol or particle in the aerosol does not have virus on it. And even if it doesn't mean that the virus is alive and actually able to infect. What you need is to be able to be exposed in the nasopharyngeal region primarily, so kind of the back of the throat to the face, and the nose, with a live virus that's able to actually replicate in your cells. And so this is just an image of where the aerosols are going. But what it's showing is you have some level of deposition happening, but a lot of it is staying within the air, some of it's being exhausted, and that's where we can start playing with some specific levers on how to try and control the aerosols within the room, because you don't know who is able to actually be the contaminator in that case. So this being set up as a classroom is a good example of being able to show how that actually works in a number in this specific environment. So next slide, please. So when we're modeling aerosols, one thing that we have to understand is that, especially when we're talking about it from an engineering standpoint, which is where most of the technology gets developed and initiated, we need to be able to look at it from the standpoint of a mass balance. And a mass balance is important because it is based in very fundamental concepts in science, such as in thermodynamics, where you can neither create nor destroy matter. So what we're talking about is we need to try and take into account computationally what is occurring with each one of those bioaerosol particles or the viruses that are being emitted on those bioaerosol particles as well. What we do in that point as well, when we're trying to do this kind of fate and transport modeling, is take into account what's going through the HVAC system, but then also take into account what's being breathed in by the people who are in that room. So there's things like respiration rate, tidal volume. When you take a breath, there's a certain amount of volume of air that's actually going into your lungs. You know, those kind of things, we can start estimating a per person or population scale risk of contracting COVID-19 or otherwise just being exposed to SARS-CoV-2 in the aerosols in the room. From there, what we do is we're creating basically digital twins is the computational term. We're creating a mimic of your facility in the computer. And what that's doing is it's allowing us to be able to simulate through and say, this air exchange rate matched with this filtration, matched with this makeup air percentage is going to give you an overall reduction in the pathogen load, will result in an overall reduction in the health risks that you should expect on a per person or population scale. Next slide. What this does is it allows us to be able to start saying what technologies make sense, what barriers make sense. So the Swiss cheese model has been talked about quite a bit, and it's a good one overall because you can see where you can get this pass through from one barrier to another from the different technologies and interventions that you have in place. Not all interventions are a technological intervention. Some of them are also administrative or personnel based. And what we also want to see is on this image is that not only do we have it where we can have that pass through, but if you don't have the appropriate maintenance and operations in place, a 3-year-old going insane, sorry. If you don't have those kind of controls properly in place and you don't have a good maintenance cycle in line, you're going to start getting degradation of those barriers overall. So if you've heard the multiple barrier approach, that's what we use traditionally in engineering. The Swiss cheese model is what's been gaining popularity and overall use in public health and other fields, but it's the same basic thing. Now, the questions always come, what technology is the best? Which one is the one that I should get? That is not a simple question, and it's not a simple question because we're trying to be difficult. It's not a simple question because we need to understand that some of these barriers may interfere with each other. They may be complementary to each other, but they're not. There isn't one that you can say is the one that's going to work. They have to work in unison with each other, and it's a system. You need to look at the system, look at how the system is operating, and go from there. So in engineering, we do this all the time on drinking water treatment, food quality protection, things like that. This is just another thing that we need to bring into the indoor air space. So next slide. So when we're talking about it from the risk assessment side of things, this is where it becomes that important to be able to understand that what we're creating is what's called a digital twin, or a representation of the facility inside the computer. And what we can then do is we can change around how people are behaving, how they're moving around, whether or not they're wearing masks, whether or not they're wearing masks properly, what kind of masks are they wearing, plus your air exchange rates, plus your filtration, plus any other treatments that you may have, plus the makeup air, and all of those are going towards your overall system. So your business operated controls, your you know, in that case, it would be like controlling who's coming in during a retail environment, and you know, personnel controls, or personal controls. You have what kind of compliance do you have with staff, faculty, students on actually wearing their masks, and how they're wearing their masks, what kind of masks they're wearing. Facility and building controls are what Randy's going to talk a lot more about, so I won't go into too many details about that. But what we're basically getting are these curves that you can see to the right. And the important thing about those is that what you can start doing is you can start staging down what those risks are. So there's something called inherent risk and residual risk. So what you're seeing here is an inherent risk to a healthcare facility that we've modeled, and extended that to public schools for some schools in Ohio. The residual risks will be under that on a consistent basis. So what you can start doing is you can start looking at it from a cost benefit standpoint as well. What can you afford? What can you afford to maintain? Because if you can't maintain it, it's not really worth time or money putting it in. It could be detrimental because you could have spent the money on something else that you can actually maintain and would allow you for a much higher level of resiliency in the future, because this isn't the only pandemic we're going to have to deal with. So we want to start thinking about now as well as what will happen into the future. So go to the next slide. And this is where it also ends up becoming important, understanding that much more about your mechanical ventilation system, different from HVAC. And you know, Randy's definitely going to be able to talk about that in much more detail than I can. But a mechanical ventilation system is where you're going to be able to move the air around effectively. You can tune that specifically to be able to try and deal with pathogens, but we also need to know about the dynamics of your space. Do you have congregation of people in a specific area? Is there a way of being able to make sure that the airflow is more directed away from that particular area? We're going to get more congregation of people. We can then build in these digital twins where we pop in different locations within the room where the contaminator or the person who's spreading the infectious agent is likely to be or may be at some point. Then depending on whether or not you're using an entrainment or a displacement type of ventilation system, understand how that's going to spread throughout the room, or if it's going to be isolated more to the ceiling where the exhaust and exchange area is for something like a displacement ventilation system. So there's a lot of things that we can do by way of being able to just sit down, figure out initially what it is that you're trying to control, in what ways, for which populations, under which constraints, figure out what it is that needs to be done. But it really does come down to understanding your system and being able to look at it from a computational and quantitative sense to be able to say what technologies and what behaviors and what actions, and all these are plural, are necessary for you to be able to limit it. So it's definitely not a one-shot deal. We want to stay away from the idea of a silver bullet on anything that we're trying to control, and especially in indoor air risks like this.
Thanks, Mark. I'm going to really start where Mark left off with proceed with caution. I think we've seen way too many school districts and other clients, building owners, say this is the magic bullet that we're going to install, and we're going to spend $3 million to put in something that may not even work, that hasn't really been tested. I've worked with many different school districts, many different sizes of school districts. Minneapolis School District has 76 buildings, and all the way down to school districts with 1 building. But I've seen school districts spend up to $3 million on equipment that right now is questioned to see even if it works. So, you know, when we get into crisis mode, often have to make quick and tough decisions. But we're really stating, let's do the homework. So really establishing what you need. And we've seen a lot of school districts make decisions based on what manufacturers are telling them. I know a lot of manufacturers are going and selling clean air technologies. And I'm going to talk about a few of those today because we've tested a lot of them in our office. And so, you know, that's something that we really caution district owners to wait for the research to make sure that you have a team built that can provide you the options and that can provide you cost benefit analysis like Mark mentioned, because it isn't a one size fits all. Really need to look at all the criteria. The HVAC systems, all the different components work together, and it needs to be seamless in order for them to produce the best building performance. So next slide, Richard. So just a recap of relative particle size. You see way to the left, third from the bottom is coronavirus. It's very, very small. And we've, Dr. Altman and Mark talked about the virus attaches itself to droplets, you know, can be in the less than 1 micron range. And so that's when you look at all those other particles, and this is what we're fighting against. And we've since March of 2020, we've said, hey, it is in the air. We've seen many people just, you know, close contact, really don't touch anybody and contact the COVID virus. So this is what we've been battling and trying to figure out for the past 8 or 10 months is how do we protect people from that small virus? So that's what I'm going to get into in the next few slides. So there's many different types of HVAC systems. You know, everybody on here probably has one of these systems in one of their buildings. The different types of HVAC systems. Some buildings I've seen we've been into have steam and hot water radiation. They rely on outside air through operable windows. So they really have no forced ventilation system. Some of them have overhead or underfloor distribution systems. Mark mentioned displacement ventilation, another type of ventilation system. Demand control ventilation, where you're actually controlling the amount of outside air based on the number of occupants. Some systems have heat or energy recovery wheels in them. That middle picture is a picture of an energy recovery wheel with UV light on it. So, but there's, like I said, there's just so many different types of systems that really one size doesn't fit every building. Next slide. So just talk about some of the possible ventilation is just the total airflow in the space. Is there any airflow in the space? We do a lot of smoke testing in buildings when we do our assessments to see actually where is the outside air being distributed, where is the supply air grills, where is the return air grills, is the air short cycling just from supply right back to the return and really not even going in the occupied zone. You can see the photo on the bottom. That's a smoke test. Really the air is just hanging right above where a student would be sitting. Doesn't even reach the student. It just literally sits there and hangs there and goes right back to the return. So you can see there's just not enough mixing there to really remove those contaminants in the air. And those contaminants could be CO2, they could be particulates, they could be total VOC or TVOCs, they could be viruses, anything that is, you know, floating in that air. Next slide. So I'm going to start in talking about how do we handle this. And the step one is really develop a building readiness plan, which is recommended by ASHRAE. So some of you may know that ASHRAE came out last year with a really a checklist. I think it's up to like a 200-page document now. They've updated it a couple times over the past year. But really looking at your air handling systems, your HVAC zone plans, looking at, do we need isolation rooms or negative pressure areas? We've developed a ventilation management matrix, which really takes a number of things into account, looking at outside air, looking at your existing filters, the sizes, the MERV ratings, and developing that matrix for essentially the entire building on one 11 by 17 plan that can really help develop the recommendations. And some of the recommendations we've come up with match what ASHRAE comes up with. Increase ventilation as much as you can afford. Obviously in California, it's the cost of cooling the air most of the year, or in some cases heating the air. Increase filtration. Can you increase the MERV rating in your filters? Does the equipment actually, is it designed for the extra static pressure from increased filtration? And then we're going to talk a little bit about air cleaning technologies. There's a number of them out there, and I'll get more into that in a couple slides. So talking about improving indoor air quality. So there's a lot of different things we base that on. The building use, the HVAC system. We talked about all the different types, the age of the HVAC system. I just did a study a couple months ago where they wanted to increase MERV ratings, see what we can get on filters. And I took one look at the air handlers, and I should have put a picture in there. And the filter racks were so badly damaged that there was no sense putting in higher MERV rating, because essentially half the air was going around the filter racks just because of the damage over 35 years of that air handler. So we recommended you need to replace at least the filter racks and probably your whole air handler before we start looking at increased filtration. Looking at airflow distribution, we mentioned that it's critical in a HVAC system, especially in a school facility and classrooms, that we get adequate airflow distribution across the entire room. I've seen a lot of spaces where we do smoke testing. It covers the top half of the room, or the air only goes to one end, like Mark showed on that one diagram. And then also looking at occupancy, density, and activity, looking at the space specifically for that HVAC system, and does it match, and looking at how many people are in that space. Next slide. So talk a little bit more about filters. So here's a MERV rating table. And so we really, in most systems, sometimes have MERV 8 coming standard from a factory. I did a senior housing study a month ago, and they literally had MERV 5 filters in their equipment coming from the factory. And most of that equipment wouldn't even handle a MERV 8 filter. But ASHRAE recommends a MERV 14, minimum of a MERV 13. And so when you look at the second column, which is in that COVID particle range, that's really when you start trapping some of those particles. And we'll talk a little bit about air cleaning technology that actually makes particles larger, that will actually increase the amount of particles that we actually can collect in a filter. We can go all the way up to HEPA filters in some systems, and we'll talk about that too. But then you're getting into the MERV 17 and higher filters. Next slide. So I just want to briefly mention what we did in our office. Our office is about 35,000 square feet. We have about 90 people in our office. But last March, we said, well, we really can't shut down our office because we have state projects, we have school projects, we have a lot of different types of projects that we need to keep designing. And we had to come up with a way to not only make our staff feel like the safe coming in the office, we had to find a way to improve indoor air quality for our clients as well. So back in March, we spent about 60 days doing a lot of different research, seeing what was out there. And then we implemented a number of these in our office. And then we had a third-party testing agency come in for a week in June and do testing with systems running, systems off, and doing a combination matrix of those. And it was really telling of what was actually used to improve. So we use side stream portable HEPA filter, fan filter units, because we had a heat pump system that couldn't withstand any more filtration than what we had in there, which was about a MERV 8. So we put in 9 different portable fan filter units with HEPA filters in across the building, including in some mechanical rooms that had a common return. We did put in needlepoint bipolar ionization, and we tested about 4 different manufacturers of bipolar ionization. We already had UV technologies in some of our air handlers, the main air handler that brings in outside air. And then we did our baseline testing for ozone, TOVOCs, ions, and particle counts. And so what we came up with was, at the end of the testing, is we had about a 65% reduction in particle counts in the COVID particle size range, which for side streaming about 20% of our air we thought it was very good results. And as Mark talked about, it's not just one thing. We think it was a combination of the things we did to get that improvement. And it shows on that chart that Mark showed at the end is what we tried to do is reduce the risk. For every occupant in our office, we tried to reduce the risk of them coming in the office. Next slide. So what we've learned, obviously do the research. Not all new technology has been tested. Not all equipment's the same. You know, we've tested 4 different types of bipolar ionization, all different results. Tested in the same heat pump and serving the same room. Some systems produced ozone, some didn't. So it's really understanding the differences between equipment. Every equipment manufacturer will state that their equipment's the best, that they've been third-party verified. I just had 2 emails today from equipment vendors saying, yep, we passed the UL testing for production of ozone, which UL's listing still lets them produce some ozone, but those are things that we want owners to understand. Really understanding the life cycle cost, as Mark and Scott mentioned, is understand the installation, operation, and maintenance. Don't put something in that you can't maintain, you can't afford to repair. Some of these ionization systems require tube replacement every year or 2. There's just not one magic fix. It really depends on the type of system and the type of building that you have. And then last bullet point is to hire a firm to help out on these. So just talk a little bit about the airflow distribution. And you can see coming out of the unit is air floating around. And if you have an affected person, and essentially is that if you don't have the returns in the right spot, that return air just sweeps straight across across the supply air and can affect a number of people, even though that if we had the return air or exhaust air on the other side, you would essentially be exhausting that air. So it's important to really look at that airflow distribution for existing spaces. Next slide. Talk about a little bit about new spaces. So with new spaces, obviously we can do a lot of different things. We can design the air handler system for MERV 13 or 15. We can design the filter racks for staying less than 300 feet per minute. We can put in outside air filters to pre-filter, to remove dust. So there's a lot of different things we can do on new systems that obviously on existing systems, we have to be a little bit more creative on what we can do. But I bring up the using side stream filtering is another way that we can do or put more filtration on an existing system without removing the existing air handler. Next slide. Talk a little bit about so just reviewing what we brought up before on the supply. Location of supply air grills and return grills are very, very important. You can see on the right side is your normal air distribution where everything is supplied from the ceiling and it's returned at the ceiling. You get some short cycling, you may push some air down to the breathing zone, but essentially goes past some people and back up the return grill. What we like to see is if we can separate those two. Put the supplies at the top, put the grills closer to the floor, and pull that air across the breathing zone and not return it back across. Now you can't do that in every building, but that's really the goal, is to provide that airflow distribution across the entire zone. Next slide. Talk a little bit about air monitoring and different types of monitoring. There's a lot of different monitors coming out. We bought several monitors for air quality monitors so we can bring in and do some HVAC assessments, both pre implementation and after the implementation, just to verify that the systems are working. There are some monitors now that we can install to provide real-time data. You know, what do we have for ions in a space? What do we have for CO2 in a space? Some of you may have these systems already. There's more and more technology coming out. Just listened to a webinar about a week ago. There's one company that is putting out a monitor that says that they can detect COVID particles live. Obviously, it's very expensive. It's like $15,000 for one classroom, and it's $750 per quarter to change out the elements in the event of a COVID alarm going off. So obviously very expensive. Probably wouldn't recommend that to anyone right now, but there's many different types of air monitoring that can be included, or even handheld devices that can be used. So the next slide is just a recap of what Scott provided. Is not only do we want to improve air quality to reduce the risk from COVID or any other pandemic in the future, but just as Scott brought up in his slides, it provides and these studies are out there. They're in USA Today. You can look them up. Many different studies coming out in the improving air quality. Huge reduction in student and teacher absences, 30% up to a 30% reduction in substitute teacher costs and lower medical claims. Improvement in test scores. That's been well studied, that improving indoor air quality can largely improve academic results, and then lowers workman compensation claims and costs. So when you look at the life cycle costs, these should also be included in some of those ROI calculations to determine, does this provide a payback? So call to action. So what do you do now? And I'll just take a couple minutes to go quickly run through these. Obviously, there's a clinical and human factors assessment. It's really, what should we do to provide more defense? And looking at items 1 and 2, just what are the tools needed? Monitoring checklist. I know that question it comes up on almost every seminar we do. And just the expertise and the skill set required is, you really need people like Scott or someone on a team to provide those action items and develop those checklists in order to provide that. So number 2, part 2 of that is, well, I guess part 1 continued. I forgot there was 2 slides on here, is to review the maintenance of facility team skills and really build that team. We've developed preventive maintenance manuals for after the implementation, to make sure the systems that we're implementing are maintained and controlled, and then coaching tools, just in terms of the leadership practices and identifying all those conditions for monitoring the HVAC systems. And then part 2, which is the next slide, is engineering assessment. Where do we go? Well, how do we even get started with this? So it's really it's a 8 to 10 step process that we do as walkthrough with a school district, looking at existing systems, creating that ventilation matrix, management matrix I talked about, reviewing test and balance reports, or redoing test and balance reports so we know what's actually happening. And really, you need a NEB certified commissioning engineer or licensed mechanical engineer to assist with that. And it's really looking at developing that first look at what do I have in my existing building for HVAC systems. Step 4 is doing that air testing I talked about, bringing in tools to monitor your air and test your systems for a baseline. Next slide. And then that part 2 of that continued is the evaluation compared to ASHRAE 170. Developing HVAC zone plans is we really think it's critical to know which air handler is serving which zone. We were recently at a Midwest university, and we got a call that one of their air handlers wasn't cooling, and they said it's this air handler. And we had a couple engineers look at the plans and said, nope, you don't even know which air handler it is. That's the wrong air handler. So they were making adjustments on an air handler that they thought served that zone, and it wasn't even that zone. So it's important to know which air handler serves which zone so we can make those implementations. So, when you look at the expertise required to do these modules, it's very important to bring in a team to do that. And I think that finishes up our slides.
All right. Thank you to, I don't know if you guys can hear me okay. Can you guys hear me? All right.
Okay.
Thank you to our partner LifeWings for discussing the new Safer Air news. We will now enter the question and answer segment of the webinar. You can ask questions using the questions tab of your GoToWebinar dashboard. We will try to get to all your questions today. So I do have some questions. I have about 10 questions I'll ask the panel. Number one, I think you mentioned this just a minute ago, Randy, but are there any checklists or worksheets school staff can use in preparation for evaluation of their air quality management systems?
Yeah, that's a good question. And ASHRAE's developed a preliminary checklist as part of their 200-page document. We've taken that to the next level and really put together a checklist for doing the initial assessments and then continuing with the preventive maintenance checklist of any implementation. So it's really not only the assessments, but the implementation and then following up with maintenance so those systems can be maintained in good standing.
Awesome, thank you. Another question we have is, how often to change HVAC filters? Is it better to change all at one time or each unit as needed based on use?
Another great question, and we get this question a lot. Especially during the pandemic, it was critical to change out filters probably more often. But we also stated that you probably want to wear gloves and mask when you're changing out those filters, because those filters will collect, especially if they're HEPA filters or MERV 13 filters, they will start collecting COVID viruses or other particles that could be dangerous. The question, is it better to change all at one time? We say it's for each air handler. You can change, if there's 16 filters in one air handler, you should change all 16 at one time. Not necessary to change all air handlers at one time. If it's part of your maintenance schedule to change 5 air handlers per week and you have 20 air handlers, that gets you through a month where you're changing 5 air filters and 5 air handlers a week, and then you can do 20 in a month. So it's kind of up to the building, how many units there are. Some buildings are probably small enough where you can do them all at one time. But those are the types of things that we look at. And we really like to use some type of monitor to determine what is a static pressure loss going through the filter. Is it loaded up that it's causing either more motor horsepower changes or energy use changes when we change them? Got
it. Thank you, Randy. How to apply for AB 841 grant? Do the applications open? So the question is, how do we apply for that?
James, it's Richard. Yeah, it's Richard here. We're working in any number of states, right? And the 841 is one of the California state-based grants, and we're helping people apply for the ESSER money and the CARES Act dollars and ESSER 1 and 2. And we've worked with, higher education as well as high schools and unified districts and different types of systems. So we've got a lot of experience at that. So we can certainly help with the application. For instance, many of the states in the Southeast are, requiring very specific items in the assessment. And the application has to include, what are the very specific steps for the assessment. And we have all that ready, tailor-made. So we can certainly help with that. And any of the other grants that might be coming. I know California has a couple of others that they're trying to get finalized as we speak. We just got an update on that yesterday from the school housing group.
Okay, perfect. I am very interested in the effects of, ionization?
Ionization, this one might take a while to respond. I'll try and answer in just a minute here. So ionization, there's many different types of ionization. Ionization has been around for a long time. I mean, it's been used for smoke eating in bars and casinos for years. It's developed in the late 1800s. Recently, needlepoint bipolar ionization came out, and there's a lot in the news about some types of ionization requiring adverse effects, producing ozone, creating formaldehydes, because you're actually electronically charging particles in order for them to collect different negative or positive ions in the space. So we've done a lot of testing on it. We have a lot of information. I'm not going to go into different manufacturers in this seminar. I'll be glad to meet with different owners to talk about it. There are many different reports out there about some ionization systems actually killing COVID particles or eliminating them in a test box. Some of that's being questioned right now, whether it actually kills COVID. We've never believed that it actually kills COVID. It may, but we're not saying that. What we think ionization does do is increase the particle size, so particles are easier to collect in filters. But yeah, there's a lot going on in ionization news in the last few weeks.
Okay. Our district deployed freestanding air purifiers in classrooms to mitigate aging HVAC systems. How much does this help?
Yeah, that's what I talked about when I talked about side stream. Depends on what type of air purifier. Again, lots of different air purifiers out there. Do they have HEPA filters in? Do they have a combination of some germicidal effect? There's many different types out there that use different things. Some have UV in them. Some of them have ionization systems included in them. So I'd really need to know on what type of air purifier. I'd say if it has a HEPA filter in it, it probably is producing some positive effect.
Okay. What is the most effective technology and best price effective unit? Kind of a general answer.
Yeah, that's going to be a tough one to answer without knowing what the building is, because I would say, going back to our original discussion, is one size doesn't fit all. There's no silver magic solution out there. It's really looking at the building, what is most beneficial. Sometimes we say, first of all, let's get your building up to code and bring in enough outside air for each student. That's maybe the first thing. The second thing we look at is filtration. And then the third thing we look at is some air cleaning technology. Some districts say, I'm not going to spend money on air cleaning technology, and we're fine with that. We're trying to improve the indoor air quality in any way we can. And you necessarily don't have to do 10 steps to get there. You may do 5 of the 10.
Perfect. Have you worked with other school districts or COEs, and what size local education agencies have you worked with?
Another good question. We've worked with Minneapolis School District. We had 76 buildings that we did HVAC assessments for, all the way down to school districts that had 1 or 2 buildings. Most of them are in that 10 to 25 buildings per district. Done a number of them across the country. So yeah, we're comfortable in dealing with smaller districts all the way up to large districts.
Perfect. We had one just come in on the chat. How can we get the checklists and worksheets that were mentioned in response to the first question?
The ASHRAE information is all public. When we're starting to work with clients, we'll send them samples of our work. We don't issue those because they're proprietary documents, just to put them out in public. So, but if we have a call, they call Richard or myself, we'll be glad to start talking to them and talking about how we can help them and provide some sample work.
Got it. It can be expensive to maintain and operate buildings with high air quality levels, particularly through the extreme cooling season. How do you find a balance between cost, safety, and functionality?
Yeah, and that really leads back to looking at each building individually. Sometimes it's very simple changes, and what we've done in our assessments, we actually put them in 3 groups. The first group is changes the district can do immediately. It may be changing outside air damper settings. It may be doing something that's just very easy to do. Second group is these things may cost something. Changing filters to a higher HEPA or a higher MERV rating filter. And then the third is more on capital improvements, and maybe be changing air handlers, maybe changing airflow distribution in an entire school building. Or adding airflow distribution in a school building. So it's really 3 different categories of how you look at what is the cost and what is the cost, a return on investment for facilities. And then you really have to add back in is, what else are we improving? Are we improving test scores? Are we improving teacher and student absences? And looking at that part of on the ROI chart as well.
Got it. And last question, you did touch on this, Randy, but maybe you want to go a little bit deeper. We have seen CO2 monitors being mentioned in the news, recently, and can they help with monitoring for COVID?
That's a great question because, and I've seen this question before. So CO2 monitoring we've used in school facilities for 20, 25 years. The issue was they're tough to keep in calibration. We're actually testing a CO2 monitor now that actually is supposed to last 15 years without calibrating. We haven't got to the 15 years yet. We just started testing it last year. But the typical CO2 sensor that we had put in a classroom would essentially, you'd be calibrating it every two years. The issue with CO2 monitoring that we see at the start of the pandemic is, yes, CO2 monitoring will show essentially how much outside air you're bringing into a space, and it'll show that you're diluting a space, but it doesn't look at total VOCs, it doesn't look at particle counts, it doesn't look at ions in a space. So CO2 monitoring can do part of it, but it won't do everything that we're looking for when we're looking for improving outdoor air quality to reduce the risk.
Okay. And we do have one last question to the panel here, as we're concluding, and this is all the questions we have, but other than COVID, how does improved indoor air quality help with student learning retention and achievement scores?
Yeah, and that one we touched on before too. It's a huge, I mean, there's test results or study results all over that you can find. We know that in improving indoor air quality, increasing ventilation, reducing the amount of particles in the air, no matter what size they are, all the way down to the virus size, can improve student test scores and academics. We've been into a lot of school districts where we're measuring CO2 levels of over 3,000, and you can get student complaints even starting at 2,500 to 3,000 parts per million on CO2 levels, where students are saying, I got headaches, I can't stay awake. So it makes a huge difference.
Awesome. Well, thank you guys. Thank you to our partner Life Wings for discussing the new Safer Air initiative. We are going to conclude, but I just want to say thank you to all of you for joining today, and especially those who contribute to the questions. To view our recent webinars, be sure to check out our YouTube page at youtube.com/CSBA video. If you're interested in attending future CSBA webinars, please go to our website at www.csba.org/webinars. And today's recording and slide deck will be available to view on our webinars page by tomorrow afternoon. So many thanks to our presenters, Richard, Randy, and Mark, and Scott, Dr. Altman. We really appreciate your time, and thank you, and we'll see you next time.
Thank you.
Thank you.